So invasive fungal infections. So the outline of the topic would be introduction. What are the risk factors in general for any fungal infection? Some definitions, and I'll be discussing about three important fungi: the Candida, Aspergillus, and your Mucorales, and just a mention about some important points of the IDSA 2016 guidelines. Okay, so why is fungal infections a problem? So fungi, they generally produce disease only when your immune system is compromised or when some mucosal or integumental barriers are disrupted. Fungal cultures, they lack sensitivity and specificity in some cases, and diagnosis is therefore based on a combination of factors. And the antifungals which you use to kill the fungi, they're actually more toxic to the host because of the similarity in the metabolic pathways. Okay, so basically, uh, uh, your cholesterol metabolism is the one that is there. So ergosterol in case of fungi. So basically the metabolic pathways are similar between your host as well as your fungi. And fungi form biofilms on a variety of indwelling devices, which makes the treatment more difficult. Now, what are the risk factors for all the fungal infections? So when they ask about the risk factors, you can mention this, and I've mentioned specific risk factors for the specific fungi also. So general risk factors are if the patient has an underlying diabetes mellitus, kidney injury plus or minus RRT, parenteral nutrition, acute severe pancreatitis, high Apache 2 scores, prolonged mechanical ventilation, if there is a presence of your CVC and your urinary catheters for a longer time, use of broad spectrum antibiotics for a longer time, prolonged ICU stay, any major surgery, and burns. So these are the general risk factors for any fungal infection. Okay. Now, what are the contributing factors? Vast majority of pathogens are present. A lot of immunocompromised hosts are increasing. Okay. Then longer time for culture results. So treatment becomes difficult. Identification becomes difficult. And upon that, a lot of steroid use is going on. And during the COVID time, it was still rampant. That's where your mucormycosis had become very popular that time. And emergence of a lot of MDR, Candida auris or Candida krusei, and the use of biomarkers are actually making the diagnosis more easier. Okay, so you're actually diagnosing fungal infections a lot nowadays because of the use of biomarkers. Now, coming to the definitions, very, very important, both in your theory, practical, and in your normal understanding. Okay, so what do you mean by prophylactic antifungal therapy, empirical antifungal therapy, and preemptive antifungal therapy? Okay, now coming to the first one, prophylactic antifungal therapy. So this can be of two types: primary prophylaxis or secondary prophylaxis. Primary prophylaxis is administration of antifungal agents to patients who have not had a prior episode of invasive fungal infection and are at a risk for developing one. So there is one of the risk factors, like the patient has an underlying diabetes, uncontrolled diabetics. Patient underwent a major surgery. Okay, but previously these patients have not been exposed to any infection, fungal infections. That is your primary prophylaxis. What is secondary prophylaxis? Here, there is a risk factors plus there is a prior exposure to a fungal infection. Okay, in such cases, that is known as a secondary prophylaxis. Now, coming to the empirical antifungal therapy. It is nothing but administration of antifungal therapy to febrile patients during the period of neutropenia. So, in neutropenic patients, when you administer antifungals when there is a fever prior to a confirmed diagnosis of an invasive fungal infections, that is known as empirical antifungal therapy. What is preemptive? Preemptive means you initiate the antifungal therapy only when you have either a clinical, radiological, or your biomarkers positive. Okay, at least one should be positive to start the antifungal therapy. That is known as your preemptive therapy. Okay, so I think you're clear with the definitions. Next, so we'll go with each of the fungi. So first we will be dealing with your candidiasis. So a lot of candida species are present. Okay, so the most common among them are your Candida tropicalis, Candida albicans, Parapsilosis, glabrata, and recently your Oris and your cruzi. Okay, so important thing you should remember is your Candida glabrata has a high fluconazole resistance. Okay, so hence it is most probably resistant to all the azoles also. Candida krusei is actually inherently resistant to fluconazole, but it is sensitive to oriconazole. So if you get a Candida glabrata, try to avoid any of the azoles. But if you get a Candida krusei, you can treat with oriconazole. Okay. Now coming to the predisposing factors, actually I've already discussed about the risk factors in general. Additionally, GI perforation patients are much more prone for your invasive candidiasis. Now coming to the syndromes or the presentations. Okay, so the most common presentation would be your candidemia leading to sepsis and septic shock, acute disseminated candidiasis where there will be a cutaneous manifestation, endovascular infection. So it can cause infective endocarditis or infections of your implantable cardioverter defibrillator, your ICDs. It might cause osteomyelitis or arthritis, endophthalmitis, and chronic disseminated candidiasis. Okay, so these are the syndromes by which a candida can present. So why is not your UTI nor your LRTI is included in this? Because it is actually a commensal over there, candida. So you can't tell that candida is causing your LRTI or UTI. So these are the manifestations, invasive manifestations of the candida infections. Now, how to diagnose it? Okay, so there are lots of ways to diagnose candida infections. So one is your candida colonization index. Okay, so how do you calculate your candida colonization index? It is a number of sites colonized by candida. Okay, so when you do the cultures, your blood is come positive divided by number of body sites surveyed. Okay, so if the score is more than or equal to 0.5, it is considered positive. Okay, so that is about your Candida colonization index. So number of sites colonized by Candida. So you think two sites you found that Candida is positive in the urine and in your blood. Okay, and you have surveyed around 3. So it is around 0.5. So in such cases, you need to treat it. Now coming to the scoring systems. So you have a lot of scoring systems. You have the Leon, you have the Ostrowski-Zeschner scoring system, the Shore, and your Nebraska. Okay, so important one in this is your Ostrowski-Zeschner scoring. What is it? I'll tell you in the next slide. Next, blood cultures. These are gold standard, but when you come to the sensitivity, it is only 50% sensitive. Then comes your beta-D glucan. So it's a pan-fungal marker with sensitivity and specificity around 80%. So you can add your mannan and anti-mannan antibodies also here. Okay. Then comes your PCR methods, your MALDI-TOF. Okay. And PNA fish, and sometimes to differentiate CNS candida, you can do a T2 candida based assays which uses an MRI detection to differentiate between Candida albicans and your Candida glabrata. So this is how you diagnose your candida. So one more index which I forgot is your candida score. Okay. So candida score is abdominal surgery 1, sepsis septic shock 2, total parenteral nutrition 1, multifocal candida colonization 1. So if the score is more than 3, then it is 77% sensitive and 68% specific for your invasive candidemia. So Canada Colonization Index, I've already discussed. It is also known as the Pettit score. And as I told, there is one score which is your Ostrowski-Zeschner score. So here, central venous catheter. So there should be a presence of central venous catheter plus more than 2. What are those? Total parenteral nutrition, patient on hemodialysis, patient has pancreatitis, patient on corticosteroids, or patient is immunosuppressed. Any of these two plus a central venous catheter in place, then 73%, 74% chances of having invasive candidiasis. Okay, so this is the one. Now, treatment of invasive candidiasis or invasive candidemia. So, the first line drugs are your echinocandins, especially used for moderate to severe illness. These echinocandins, they are sidle drugs preferred for critically ill or those patients who have a recent azole exposure. And the data shows improved survival with echinocandins compared to your triazoles. But it has poor penetration into eye, CNS, and urine. So if you have any infections in these areas, then echinocandins is not a good option. Okay. Now coming to the triazoles. So this can be used, your fluconazole can be used in mild to moderate cases. These are usually static drugs, and these are the drug of choice for your genitourinary candidiasis because it has an excellent urinary concentration. Okay, so here you can't use echinocandin, so you can use your triazoles. Coming to amphotericin B, it is an option to echinocandins in resource limited settings. And adjuvant therapy, suppose if the source control is very, very important. Any source, please remove it, like removal of CVC if possible. And look for any metastatic infections, especially your ophthalmic evaluation and 2D echo to rule out endophthalmitis and your infective endocarditis. Okay. Now, what is the duration of therapy? So, it is 14 days of effective antifungal therapy following negative blood cultures and resolution of illness. Okay. So, this is the duration of therapy for Candida. Now, a few words about your Candida auris and Candida krusei. Okay. So, Candida auris, so it has become a serious threat to healthcare settings over the last decade, causing serious invasive fungal infections as well as nosocomial outbreaks. So it ranks a second among the critical pathogens in the WHO pathogen list. Now coming to the challenges. It is rapid and easy transmission, environmental contamination with resilience to heat and disinfection, potential for developing antifungal resistance rapidly, and it causes high morbidity and mortality, nearly 23 to 72%. So that dangerous is your Candida auris. And it is difficult to identify by the commonly used phenotypic methods, and it is difficult to manage due to resistance to azoles and a growing resistance to your polyenes. Okay, hence this is very difficult to treat. So how to diagnose this? PCR methods are the best methods to diagnose this, and the cultures. So prevention is better than cure in these cases. So proactive screening to be done, augmentation of your infection control policies to be done, and you need to educate them about this Candida auris. Now, suppose if there is an infection, how to manage it? So this management is divided into an invasive disease, if UTIs, and any colonization. So if there is an invasive disease, so if you find Candida in any of the invasive disease which I have mentioned before, or in the blood, then the drug of choice is your echinocandins. So in case of absence of clinical response and persistent candidemia for more than 5 days on echinocandins, then you need to start your liposomal amphotericin B. Azoles only if susceptibility is confirmed by testing. And what are the azoles that you use here? It is either posaconazole or isavuconazole, because both your vori and fluconazole are resistant to your Candida auris. Okay. Now coming to the UTIs, echinocandins except for micafungin, means micafungin can be used if it is a UTI. As I told, echinocandins concentration in the urine is very less. But when you see among the echinocandins, mica fungin has some of the better penetration into the urine. Okay, so better to use a combination of an echinocandins plus amphotericin B in case of UTIs. So mica plus amphotericin B. If it is a colonization, so CDC does not recommend treating C. auris colonization, that is isolation of C. auris from non-sterile body sites in absence of any invasive disease. So colonization, you need not to worry. Now coming to the next, the Candida krusei. So Candida krusei is basically an opportunistic pathogen. So it primarily affects the immunocompromised individuals, including patients with hematologic malignancies and those undergoing organ transplantation. So what are the predisposing factors? Prior fluconazole administration, neutropenia, and breakdowns in the GI mucosal barrier due to treatments like chemotherapy or radiation therapy. So it demonstrates several virulence factors. So resistance is very high with krusei. So it forms biofilms and it secretes some aspartyl proteinases which contributes to its adaptation and infection capabilities within the host. Now, antifungal resistance and what is the treatment? So as I told, Candida krusei is intrinsically resistant to your fluconazole. So it can also develop resistance to other antifungals, including your azoles, the other azoles, amphotericin B, and echinocandins. But the present treatment option which is available is your echinocandins, voriconazole, or you can use your amphotericin B. So the choice of antifungal, it depends on the patient specific factors, infection severity. If it is very severe infection, echinocandins. If you want to use voriconazole, you need to do a susceptibility testing on it. If it is susceptible, then you can use your voriconazole. Okay. So that is about your candida infections. Now next coming to your aspergillosis. So what are the most common aspergillus species? Your aspergillus fumigatus, your flavus, Aspergillus niger, and your Oraceae. Okay, so predisposing factors other than the one which I've mentioned before. So usually this is seen in immunocompromised hosts like prolonged or profound neutropenia, prolonged steroid use and immunosuppressant use, hematopoietic or solid organ transplant patients, primary immunodeficiency states, and emerging risk factors for aspergillosis now are COPD patients, liver cirrhosis, and critically ill patients, and those patients requiring more than 7 days of mechanical ventilation are the emerging risk factors for your aspergillosis. Now, what could be the presentations or the syndromes? So, most common is your pulmonary aspergillosis. It can cause acute rhinosinusitis if your NG tube is more than 2 weeks, tracheobronchitis in lung recipient patients or HIV patients, cerebral aspergillosis in case of diabetic patients, osteomyelitis, cutaneous aspergillosis, and rarely disseminated aspergillosis also. Now, how to diagnose aspergillosis? Very, very important. So, if you see, proven invasive aspergillosis can be told only if you have a positive mycology, or histopathology of a sterile sample obtained in a sterile manner. So any lymph node, any tissue, okay, which is obtained sterile form. So the histopathological diagnosis is a proven invasive aspergillosis. Otherwise, if you're using any of these scores, it is either probable or a possible infection. Okay. Now, you have a lot of criterias which are there for the diagnosis of aspergillosis. So, the first and the most important one, you need to remember this completely. The others, you can just remember the names. So your EORTC-MSG, what does it stand for? It is European Organization for Research and Treatment of Cancer, and your MSG stands for Mycosis Study Group. Okay, so this is the criteria given by them. So here you have three criterions. One is your host criterion, clinical criterion, and mycological criterion. So what is the host criterion? So what are the risk factors which I mentioned previously? Those are your host criterions. Clinical criterions is you should have a dense, well circumscribed lesion with or without a halo, air crescent sign, cavity, or a wedge shaped segmental or a lobar consolidation. So basically, your clinical criterion is nothing but your radiological criterion here. And mycological criterion. What does mycological criterion mean? Positive microscopy or culture from a respiratory sample, or it could be your biomarkers, okay, either GM or PCR positive in ball or blood. So if all the three criteria are met, okay, means patient is immunocompromised and patient is having radiological signs with your biomarkers positive, then it is a probable invasive aspergillosis. Okay, if two of the criteria are present, it is a possible invasive aspergillosis. Okay, so this is the EORTC MSG criteria. The other criteria are your ASP ICU criteria and BM ASP ICU. BM is nothing but the biomarker here. Biomarker ASP ICU criteria. Okay, so these are the recent ones, but this is the most standard one and you need to remember the criteria here. Okay. I was talking about those halo sign, air crescent sign and all. So what is this halo sign? Halo sign is nothing but you see a pulmonary nodule and around the pulmonary nodule you see some ground glass opacities. And what is your crescent sign? So you have a small air here, okay, between the mass or the nodule and the cavity wall. So between this, if you have, this is a air crescent sign. All of this indicates invasive disease. Okay. Next comes your galactomannan assay. Same as I discussed there in the biomarkers. So you can just write about the galactomannan assay. So serum 0.5 and BAL 1.0. Okay. Limitations I've already discussed there. Now coming to the treatment. So what is the drug of choice for your aspergillosis? It is voriconazole. So voriconazole 6 mg per kg IV BD for day 1, which is followed by 4 mg per kg IV BD. Please remember the doses. Doses are very important. Now alternative drugs includes your liposomal amphotericin B 3 to 5 mg per kg. Coming to echinocandins. Echinocandins are actually not cidal for aspergillus. They are cidal only for your candida. So it has only a role in salvage therapy or intolerance to amphotericin, or if there is a prior voriconazole prophylaxis which has been taken. Okay. The other drug which can be used are, a last option is your isavuconazole. And the duration of treatment here, if you see, it is 6 to 12 weeks. Okay. So that completes about your aspergillosis. Now comes the third, your mucormycosis. So that has been asked previously in your exams about the mucormycosis. So what are the clinical syndromes which are associated with specific risk factors? So I'm covering the risk factors plus the syndromes here only. So in poorly controlled diabetic, we all have seen during the COVID time, steroids, sugars high. So you have your rhinocerebellar, sinoorbital, or your cutaneous mucormycosis. Okay. In those patients who have immunocompromised state like hematological malignancies, transplants, solid or hematopoietic transplants, pulmonary, sinoorbital, cutaneous and disseminated mucormycosis is common. Penetrating trauma, burns, chelation therapy with desferoxamine, all these are risk factors for mucormycosis. IV drug uses, malnutrition, especially in premature infants, there you will see GI mucormycosis. Nosocomial acquisition, which is linked to contaminated dressings, splints for IV cannulation, etc., may cause cutaneous mucormycosis. And we don't know the etiology. Sometimes you can see even isolated renal mucormycosis. Very rare. These are only some case studies which are present. Okay. So this is how the mucormycosis present. So important for us is your rhino orbital cerebral mucormycosis. So that is the most common presentation of your mucormycosis, and this is caused by Rhizopus aureus. So how does it occur? It occurs due to inhalation of the spores into your paranasal sinuses of a susceptible host. Hyperglycemia, usually with an associated metabolic acidosis, is the most common underlying condition. That is nothing but your DKA. Okay. So what are the clinical features? So usually patient presents as acute sinusitis, that is fever, nasal congestion, purulent nasal discharge, headache, and sinus pain. And when you examine, all the sinuses becomes involved and it spread to your contiguous structures. So what are the hallmarks of spread beyond the sinuses? You can see tissue necrosis of the palate, palatal eschars, destruction of turbinates, perinasal swelling, erythema and cyanosis of the facial skin overlying the involved sinuses and or orbit. So when you see all these things, so when you do nasal endoscopy, when you see all these things, this indicates that this might have spread beyond the sinuses and most probably it's going into your brain. So what are the signs of orbital involvement? There is periorbital edema, proptosis, and blindness. And facial numbness is usually frequent in these patients due to infarction of the sensory branch of your cranial nerve 5. Now, how to diagnose this? So, direct microscopy. So, what is the stains which we use for diagnosis of your mucor? It is calcofluor white and methenamine silver. So cultures, it is very difficult to isolate. Histopathology, to differentiate mucor from other molds and to document the evidence of angioinvasion. And radiology, okay, if you have a pulmonary mucormycosis, you will be seeing more than 10 nodular infiltrates, the reverse halo sign, and pleural effusions. So what is reverse halo sign? That is the opposite. So ground glassing in the center, which is surrounded by a dense consolidation. Okay, so if you see here, this is the ground glassing and this is the dense consolidation that is present. This is seen in mucormycosis, pulmonary mucormycosis. So diagnosis of rhino-orbital cerebral infections. So how? One is you have a high risk patient. So you have a DKA patient plus patient has sinusitis, altered sensorium, infarcted tissue in nose or palate. If that is there, yes, this patient is having ROC, your rhino-orbital cerebral mucormycosis. So as I told, endoscopic evaluation of the sinuses, you need to look for tissue necrosis and obtain specimens and send for your KOH stain. Imaging to gauge sinus involvement and evaluate the contiguous structures like eye and brain. So CT is more better than doing an MRI. Now treatment. So important treatment is, other than your medical management, your surgical debridement plus antifungal therapy, both has to be started as soon as possible. Okay, you start the antifungal and please plan for the surgery as soon as possible. Elimination or treatment of predisposing factors like DKA, please treat the DKA. And what are the antifungal drugs for mucormycosis? So the drug of choice is your amphotericin, liposomal amphotericin B, 5 mg per kg OD, maximum you can go for 10 mg per kg per day. Alternatives, posaconazole only as salvage therapy, and it requires 7 to 8 days to achieve therapeutic concentration. And posaconizole's absorption is maximized when taken with high fat food. So these points have to be remembered before starting posaconazole. Adjuvant therapy includes desferoxamine, hyperbaric oxygen, GCSF, and interferon gamma, depending upon the risk factors that are present. Okay. What is the duration of treatment? So until near normalization of radiographic imaging, negative biopsy specimens or cultures from the affected site, and recovery from immunosuppressions. All these three criteria has to be met. So there is no fixed duration of treatment for mucormycosis. Although echinocandins have no in vitro activity for the mucorales, the Rhizopus aureus, which causes your cerebroorbital rhino-orbital cerebral mucormycosis, it expresses the target enzyme for echinocandins. So suggesting that these agents may have clinical utility only when this is isolated. Your voriconazole, fluconazole, and flucytosine are not effective against mucorales. The biomarkers also we have discussed. So the common biomarkers which are used, they also can't be used for the diagnosis of your mucorales. So now coming to the last part, what does the guideline tells about your treatment of invasive fungal infections? So next 5 to 10 minutes. So if you have a candidemia in non-neutropenic patients, okay, so candidemia means it is echinocandins. Okay, invasive candidiasis or candidemia means better to use echinocandins. Okay, so echinocandins is recommended as the initial therapy, but if it is a non-neutropenic patient, you can use fluconazole when the patient is not critically ill and when you have done a susceptibility testing, it is susceptible to fluconazole. Then only you can use fluconazole in case of candidemia in non-neutropenic patients. Okay, and they tell that the guidelines tell testing for azole susceptibility is recommended for all bloodstream and other clinically relevant candida isolates. So other than your urine and uh, lung, wherever your candida is there, you need to do a azole susceptibility testing. But echinocandin susceptibility testing is not required as a routine. Okay. So only in cases of Candida glabrata or Candida parapsilosis, you need to do the echinocandin susceptibility testing. Now, as a reasonable alternative, you can use lipid amphotericin B. Okay, when there is some intolerance or limited availability or resistance to other antifungal agents. Voriconazole offer little advantage over fluconazole, and this can be used voriconazole only if there is evidence of your Candida krusei. Okay, and guidelines suggest, very important point, follow-up blood cultures should be performed every day or every other day, alternate day. I don't know whether it is really feasible or not, to establish the time point at which candidemia has been cleared. It has a strong recommendation. And the duration of therapy, I've already told it, 2 weeks after documented clearance of candida from either bloodstream and resolution of symptoms which are attributable to candidemia. It has a strong recommendation. Now coming to candidemia in neutropenic patients, it is only drug, it is your echinocandins. And your GCSF can be considered in cases of persistent candidemia with anticipated protracted neutropenia. It has a weak recommendation. Okay. And as we all know, growth of candida from respiratory secretions usually indicate colonization and rarely requires treatment with antifungal therapy. Strong recommendation. Now coming to the UTIs, asymptomatic candiduria. So elimination of predisposing factors such as an indwelling bladder catheter is recommended whenever feasible, which has a strong recommendation, and treatment with antifungal agent is not recommended unless the patient belongs to some high risk group. What are those high risk groups? One is neutropenic patients. Second, this is in infants, very low birth weight infants, and patients who will undergo urological manipulations. So you're planning for some urological procedures. In such patients, if you see in urine there is some candida, then treat that candida. Okay. So symptomatic candida cystitis. So as I told, your azoles are the better drugs for your UTIs. So either fluconazole or oriconazole can be used. Suppose if there is any fluconazole resistance that is present, you can use even amphotericin deoxycholate, not liposomal amphotericin B, because it need to pass into your renal system. So the better would be your amphotericin deoxycholate. And if you find krusei, then the drug of choice for symptomatic krusei cystitis is your amphotericin B deoxycholate. Any indwelling catheter? try to remove that catheter, it has a strong recommendation. And there is some weak recommendation for bladder irrigation with your amphotericin B deoxycholate. Okay, so that is one of the things that they can try. So coming to aspergillosis, so how should galactomannan and 1,3-beta-D glucan be used for the diagnosis of aspergillosis? Yes, serum and galactomannan assay is recommended in certain patient subpopulations. Okay, like your hematological malignancy or your hematopoietic stem cell transplantation, which has a strong recommendation. And galactomannan assay is not recommended for routine blood screening in patients receiving mold active antifungal therapy or prophylaxis, but can be applied to bronchoscopy specimen from those patients. It has a strong recommendation. Now, role of bronchoscopy in the diagnosis of invasive pulmonary aspergillosis, it has a strong recommendation. So you need to perform a BAL. Now, antifungal agents for the treatment and prophylaxis of invasive aspergillosis. So for invasive aspergillosis, the drug of choice is voriconazole. The alternative would be your amphotericin B. Echinocandins are used for salvage therapy. Okay. So this completes your invasive fungal infections.